Laparoscopic Low Anterior Resection. A video case presentation. Indications: to remove malignant and benign rectal lesions, to treat pelvic endometriosis, traumatic colon, diverticulitis, Crohn's and ulcerative colitis in refractory cases. 58 years old male, known case of diabetes, hypertension and BPH, presented with bleeding per rectum, tenesmus, and increased frequency of stools for 2 to 3 months. Colonoscopy showed ulcerated fungating mass 8 cm from anal verge, assessment rectal CA. On rectal biopsy a malignant glandular neoplasm showing atypia seen, diagnosis moderately differentiated adenocarcinoma. CT showed asymmetrical wall thickening in distal part of rectum and 2 low attenuation hepatic lesions in segment 4 and 8. The representative T1 and T2 axial and coronal MRI images showing you the wall thickening along with the rectal lesion. MRI pelvis showed an eccentric mass-like wall thickening in the distal part of rectum. It measures 5.1 cm in length and 5.8 cm from anal verge. Maximum thickness is 15 mm along with mesorectal fat stranding and extension, CRM at 9 and 10 o'clock. Few sub-centimeter right internal iliac lymph nodes seen. Patient's position, modified Lloyds-Davis. Diagram showing you port placement, which is as follows: a 10 mm camera, 3 5 mm working ports and a 12 mm working port. This is what we have to take out. Moving on to surgery. After ports insertion and creating pneumoperitoneum, abdominal survey was done, then identification of inferior mesenteric artery pedicle was done. After this we move on to the medial to lateral mobilization of colon. Here as you can see we are doing medial to lateral mobilization, then dissection around the inferior mesenteric artery pedicle, then after properly dissecting the inferior mesenteric artery and left colic artery, both vessels were clipped and divided. As you can see we are clipping the inferior mesenteric artery and left colic artery, and we then divided both vessels, then we completed medial to lateral and lateral to medial mobilization of colon. Now we are separating omentum from the descending colon, and after this we did further dissection and inferior mesenteric vein is clipped proximally and divided with ligature. Now we are doing dissection over pancreas. As you can see here the whitish pink pancreatic tissue after lifting colon. Now here as you can see we are doing lateral to medial mobilization of descending and transverse colon, and after that we did splenic flexure mobilization, and after mobilization was completed we moved to the total mesorectal dissection and hemostasis is secured along the way. Dissection and mobilization of splenic flexure and transverse colon done with cautery. Here we are doing the posterior TME dissection. Now moving on to the anterior TME dissection. First of all, we marked the anterior TME plane as it is very thin. Anterior and posterior TME dissection completed before firing of the endo-GI stapler. Complete mobilization of colon was done before that. Here you can see we are doing anterior TME dissection and anterior TME plane was opened up. Anterior and posterior total mesorectal dissection completed. After dissection, 3 purple endo-GI staplers were fired, mass resected and anastomosis done by firing a circular endo stapler as you can see in video. Retrieval of sample from phalansteal incision was done. Total time for surgery is 4 hours and total blood loss is 50 milliliters. Patient had an uneventful recovery and discharged on 3rd post-operative day. Patient progress is satisfactory and currently he is doing fine and taking orally. On final biopsy, poorly differentiated carcinoma of 50 mm in size, located in 3rd part of rectum, involving the muscularis propria and pericolonic fat is seen, lymphovascular and perineural invasion absent, no regional lymph node involvement, all resection margins are free from tumor with nearest margin is 5 mm, tumor cells are diffusely CK positive, pathological grade of tumor is T3N0. Thank you.